So today, for today's talk, we have Dr. Albers. Dr. Albers completed her pediatric residency and pediatric cardiology fellowship at Vanderbilt University. She completed her advanced fellowship in heart failure and transplant at Seattle Children's. And for the last 10 plus years, she's been an attending cardiologist with the heart failure and transplant team here, working in both the inpatient as well as the outpatient settings. She enjoys caring for children of all ages with various forms of congenital and acquired heart disease, resulting in varying degrees of heart failure, from those who can be managed at home with medications to those requiring advanced cardiac therapies, including mechanical circulatory support and or heart transplant. So please welcome Dr. Albers.
Hi, everyone. Thanks for having me. I'm going to share my slides here. And we're going to talk about striving for success in pediatric heart failure today. The first couple of slides are disclosure slides. This is a slide reminding you that this talk is going to be recorded by the Seattle Children's team. And here's some disclosures that I have to share. I have no financial disclosures or conflicts of interest. I will discuss off-label use of medications in pediatric patients, which is kind of the way of life in pediatrics. This class has no commercial support or sponsorship, nor is it co-sponsored. And my last disclosure is that I am a heart failure and transplant cardiologist, and while I really love being able to offer the option of heart transplant and taking care of transplant patients, as a heart failure cardiologist, I really should be striving to avoid transplant. And so we'll talk about that today and how we can help manage heart failure in a chronic way and keep kids from needing a transplant at all. So today we'll talk about some common causes of heart failure in children. We'll hopefully by the end you'll be able to recognize common signs and symptoms of heart failure in children. We'll talk about some of the unique features of heart failure in children with congenital heart disease. We'll review the mechanisms of action and clinical application of various medical and non-medical treatment options for children with heart failure. And at the end, we'll review some indications and contraindications for heart transplant in children with heart failure. And then hopefully we'll have plenty of time for questions at the end. So to start with, we'll talk about heart failure and kind of what are we dealing with, to give you the lay of the land. Heart failure in its very basic definition is a situation where the heart is unable to maintain adequate cardiac output to meet the metabolic demands. But I'll try and convince you today that heart failure is actually much more than that. It's a clinical syndrome that results from any structural or functional impairment of ventricular filling or ejection of blood. And that situation leads to decreased cardiac output and increased venous pressures, which then initiates a cascade of neurohormonal activation and molecular changes that then leads to progressive deterioration. And as those changes occur, cardiac output gets less, venous pressures get worse, demand gets higher, and we have a vicious cycle of heart failure that really can be quite difficult to manage in the acute decompensated state. So I always think of heart failure as this balancing act where we're trying to balance oxygen delivery and demand, and I hope you kind of keep this balanced picture in your mind as we continue through the rest of this talk. I'm going to switch gears a little bit and talk about why we even care about heart failure in pediatrics. I think in the adult world, heart failure is incredibly common. We think maybe it's not so bad in pediatrics, but in fact, clinically significant heart failure in children actually is pretty common. More than 14,000 heart failure hospitalizations per year occur in the US in children. And that is rising over time, as you can see on the graph on the right there. The majority of these patients do have congenital heart disease, and the majority of those are infants, but heart failure comes in a variety of different flavors, which we'll talk about a little bit later. We also know that children hospitalized with heart failure are at very high risk of morbidity and mortality. So compared to children hospitalized without heart failure, children with heart failure have a more than 20-fold increased risk of death during that hospitalization, and they have a high risk of respiratory failure, renal failure, and sepsis, which also places them at high risk of mortality. And those are the tall bars at the end. I'm sorry, it's kind of small on the screen probably. We also know that pediatric heart failure hospitalizations are associated with high resource utilization. They often have to stay in the hospital for a long time. And this study showed that there was a 24-fold increase in hospital costs compared to children who are hospitalized without heart failure. We also know that children with heart failure have incur higher costs and worse outcomes compared to adults with heart failure. So here you can see the cost of patients with heart failure is much higher in the younger age groups compared to the older, and that although the mortality rates are improving over time, pediatric mortality rates related to heart failure are higher than in adults. So heart failure in children is a really big problem that we need to be aware of and know how to manage. So what causes heart failure in children? The picture at the top corner is actually a group of patients who we've transplanted here. And as you can see, they come in all shapes and sizes. Some of them have congenital heart disease. Some of them have cardiomyopathy. And we tend to think of two big clumps of diagnoses that lead to heart failure. So the first being cardiomyopathy, which itself has various different forms. So dilated cardiomyopathy is the most common cardiomyopathy in pediatrics and the most common cardiomyopathy diagnosis leading to transplant. Hypertrophic cardiomyopathy is also quite common, less likely to result in heart failure, but not unheard of. And certainly children who present with hypertrophic cardiomyopathy at less than a year of age are at higher risk for severe heart failure that may require transplant. Restrictive cardiomyopathy is the least commonly diagnosed cardiomyopathy, but the second most common cardiomyopathy leading to transplant, because we unfortunately don't really have any medical therapy restrictive cardiomyopathy, and it comes with high risk of ventricular arrhythmias and heart failure that, like I said, is not easily managed medically. LV non-compaction is sort of its own entity, which we're learning more about over time. This can be associated with features of dilated cardiomyopathy, hypertrophic cardiomyopathy, restrictive cardiomyopathy, or in some cases, it's actually benign with a totally normally functioning heart, and those patients can live for a long time. So LV non-compaction is something that, again, we're learning more about, but can be a situation where heart failure is problematic. And then ischemic cardiomyopathy is probably the most common form of cardiomyopathy in adults. It's rare in children, but not unheard of. We do have patients with various coronary anomalies or postoperative coronary issues that can lead to ischemic cardiac disease. We'll talk a little bit more about that. Then there's congenital heart disease, which is the other big bucket of diagnoses leading to heart failure in children. And they have their own sort of considerations when we think about those patients. Do they have repaired congenital heart disease versus palliated versus unrepaired? Are they a biventricular or a single ventricle physiology? Do they have a systemic right ventricle or a systemic left ventricle? And all of those considerations become important as we think about how to care for these patients. So the other way to think about heart failure is to separate it into heart failure with systolic dysfunction or with preserved function. So when we think about heart failure with systolic dysfunction or a weak pump, again, you can have various diagnoses falling under that category. So the big one would be cardiomyopathy, but there's lots of ways you can have cardiomyopathy with a weak pump. So the genetic or inherited dilated cardiomyopathy, again, pretty common, but you can also have myocarditis. You can have acquired cardiomyopathy from chemotherapy exposure or even arrhythmia or pacemaker-induced cardiomyopathy. As I mentioned, you can have coronary ischemia. We've even had patients present with malignant hypertension due to severe renal disease that result in cardiomyopathy, and once you treat the hypertension, their cardio can get better. In patients with congenital heart disease, you can see severe systolic dysfunction in the setting of left ventricular outflow tract obstruction, such as critical aortic stenosis or coarctation. You can see systolic dysfunction after attempted repair at congenital heart disease. So especially if there have, required a long cardiopulmonary bypass run or multiple runs, the heart can be injured during that period. Again, you can have patients with arrhythmias or pacemaker-induced cardiomyopathy. And some patients just develop dysfunction over time for reasons that we don't know. Also, a population that's special to me is the post-heart transplant patients. And We can see primary graft failure, so at the time of transplant, for whatever reason, likely due to some preservation injury during the transport. We can see that the heart just doesn't wake up working well. We can also see dysfunction in the setting of rejection or after the development of coronary vasculopathy. So again, understanding kind of where you're coming from will help you to best come up with a treatment plan for your patient. Oh, I forgot, there's also right heart failure, which is kind of its own entity. So people with, children with primary pulmonary hypertension can have severe heart failure related to right heart failure, which is sort of its own entity. We can see that in patients with right ventricular outflow tract obstruction, or we can even see right heart failure in the setting of left heart disease, such as pulmonary vein stenosis or mitral stenosis, where you have significant backup of pressures into the pulmonary vasculature and the right heart fails in that setting. So there's lots of varieties that we need to understand in order to best come up with a treatment plan. Again, now there's heart failure with preserved systolic function, so the pump is perfectly fine, but we still have heart failure because, again, it's a mismatch of the metabolic demand and the cardiac output. So there's the big group, I would say, is mostly congenital heart disease with excessive pulmonary blood flow. So you can have that in left to right shunt lesions with two ventricle circulation, such as a ventricular septal defect, AVSD, et cetera. Or you can have that in the setting of a single ventricle with complete mixing, such as truncus arteriosus, single ventricle with unobstructed pulmonary blood flow, like double inlet left ventricle, or hypoplastic left heart syndrome. You can also have significant valve insufficiency. So either atrioventricular valve insufficiency or semilunar valve insufficiency can lead to heart failure, even when the systemic pump is working just fine, because the blood is going backwards instead of going forwards, which can be a big problem. You can also have high output heart failure, so systemic AVMs, severe anemia, even thyrotoxicosis or sepsis, and these, again, where the demand is too high and the output is not meeting that demand. And then there's restrictive physiology. Restrictive cardiomyopathy is one of those where the systolic function is fine, but because of impaired ventricular filling, you still have signs and symptoms of heart failure. And then there's the Fontan circulation, which is its very own unique situation where you can have a failing Fontan, even with perfectly normal function and even sometimes with pretty good hemodynamics, when you have things like protein-losing enteropathy or plastic bronchitis that indicate that, just are signs that that physiology is not optimal. So I'm going to try and give some visual context for some of these heart failure situations. So in a normal situation, we have two circulations in series. I don't know if any of you remember back to your high school physics class when you had to draw out the circuit, and you have the little energy source, and then you have resistance markers in there. So on the right, you have your left heart pump, which pumps out to the systemic circulation. Again, systemic vascular resistance that sends oxygenated blood to the body. Then that returns back to the right side of the heart, which then pumps blood back out to the lungs to pick up oxygen against pulmonary vascular resistance, and then so on and so forth. You can see how that works. In the setting of a left to right shunt, you have blood coming back to the lungs, or coming back from the lungs to the left heart coming from the left heart, you have some going out to the body, but you also have the opportunity for some to go back to the right side of the heart. And as the pulmonary vascular resistance drops, it becomes easier for blood to go across that shunt out to the pulmonary vascular resistance. So you have extra blood flow going out to the lungs and back to the heart, and that puts extra volume load on the heart and on the lungs. And then in a single ventricle circulation, you really only have one pump that's pumping to both the lungs and to the body. In that situation, as the pulmonary vascular resistance drops, you have more and more blood going out to the lungs at the expense of blood going out to the body, and that is obviously not good. And as you as you decrease cardiac output to the body, you also decrease coronary perfusion and can actually lead to coronary ischemia, and that can be a very detrimental situation, as you might imagine. So the single ventricle is a special, especially an unpalliated single ventricle is another special situation where we're trying to balance pulmonary versus systemic blood flow. So as we think about all of those different forms of heart failure, we have systolic dysfunction, we can have pulmonary overcirculation, we can have single ventricle situation or physiology, all of which can end up leading to a final common pathway where we have inadequate cardiac output to meet the demand. We have then sympathetic activation. So we activate the sympathetic nervous system where the brain is saying, I need the heart to beat faster, I need the heart to beat stronger in order to meet the metabolic demands. You have activation of the renin-angiotensin-aldosterone system, which says, I need to retain water to keep the blood pressure high. I need to vasoconstrict in order to keep the blood pressure high. And all of those things are not very good for a heart that's struggling. Those neurohormonal cascades then activate lots of unhealthy ventricular remodeling, where we have actual injury to the heart muscle, and eventually you end up with the clinical syndrome of heart failure. And again, that's a vicious cycle like we've talked about before. This is just a cartoon that I think is really cute that I think I got from Dr. Hong at some point, but it is basically just what I just said, but it says it in a cute way, where you have the heart in the middle really struggling. You have the renin-angiotensin-aldosterone system here increasing afterload and making it harder for the heart to do its work. You have the brain asking it to work harder. The lungs are getting congested over here, and it's just it's just a whole body syndrome that takes over. So no matter what the cause of heart failure, it actually looks pretty similar on the end when you're examining the patient. So many of the symptoms of heart failure are like I said, similar no matter what the cause. We see, especially in babies, we see increased work of breathing, excessive diaphoresis, poor feeding, and in older kids, we tend to see exercise intolerance, and GI symptoms are a really big one in older kids because of inadequate cardiac output to the gut. They just don't feel good, and we've had many patients go through a very thorough GI workup for their intractable vomiting, only to find out that they have severe heart failure. We also have similar physical findings no matter what the cause is. We see that the kids are often, especially babies, are breathing fast and maybe working hard to breathe. They're often tachycardic. They may or may not have a murmur, depending on the situation. They may or may not have hepatomegaly if they're very congested, and same with peripheral edema. Sometimes we see that, sometimes we don't. Oftentimes in advanced heart failure with systolic dysfunction, we have poor pulses and poor perfusion, but in the setting of heart failure related to pulmonary overcirculation, for example, you may actually have bounding pulses. So kind of depends, but the symptoms are relatively similar across the diagnoses. For lab evaluation, when we suspect heart failure, we start with a pretty thorough lab evaluation looking for electrolyte derangements and organ dysfunction, acidosis. We always send blood counts. We know that anemia can either cause or exacerbate symptoms of heart failure. We always check iron studies. We'll talk a little bit more about that later on. BNP can be helpful in determining, helping you to understand the degree of heart failure. And then at some point, depending on the situation, we may end up doing genetic testing. For diagnostic studies, these are the basics. I think primarily the echo is the first line in helping us understand what's going on with the heart. We're looking for ventricular function, chamber dimensions, anatomic abnormalities, but sometimes cardiac CT, an MRI, and even cath may be needed to help seal the diagnosis. And cath can sometimes even provide interventional opportunities to help treat the heart failure. For monitoring, I don't know, this picture made me laugh because it's how I felt the first time I walked into the ICU as a medical student. I was like, what is going on in here? But we do need a lot of those lines and wires to help us understand what's going on with our patients. So we use telemetry monitoring. In the ICU, we do monitor central venous pressure to help us understand the volume status of the patient. Arterial line can help us understand blood pressure and also provide nice access for labs. And then NIRS monitoring to help help us know about regional cardiac output. So cerebral and renal NIRS is what we use in our ICU here. Swan-Ganz catheters are indwelling pulmonary artery catheters, which you really don't use in pediatrics, but they use them a lot in the adult world to give real-time information about the hemodynamics. So that's sort of how we think about and diagnose heart failure. And then once we know that we are dealing with heart failure, how do we deal with it? What are our management options? So the first thing we really need to understand is the clinical state of our patient. And this is a pretty basic diagram. And as you can imagine, cold and wet, nobody likes to be cold and wet like we have been in Seattle for the last couple of months, although it's been really nice the last week or so. So that's good. But we would all prefer to be warm and dry. And so these are sort of the categories that we think of when we're examining and evaluating a patient with heart failure, and we want to try and get them to that warm and dry state. So this is a diagram from a recent publication about heart failure therapies, and it's basically the diagram that I showed you a little bit earlier about the cascade of heart failure, but this includes little targets of where our therapies can act along those pathways to try and help restore the balance in heart failure. So we'll talk about each of these treatment options and their targets along the way. So medical management of acute heart failure really focuses on restoring that balance of oxygen demand and delivery. The aims of medical therapy in acute heart failure are primarily symptom relief. We really want to work to maximize oxygen delivery and minimize oxygen demand, and to restore and maintain end organ function. So the first line therapy in acute decompensated heart failure is really inotropes and diuretics. Inotropes help improve symptoms in patients with hypotension and hypoperfusion. And diuretics improve symptoms by relieving pulmonary congestion and decreasing filling pressures. And the simple act of getting some volume off can actually help the heart function better. If you remember the Starling curve, the Frank Starling curve, where those myocytes get really stretched out from being volume overloaded, they just can't make their connection and do their myocardial contractility the way they need to. And simply getting the volume off and getting those dimensions, getting those myocytes closer together can help them to function better. So diuretics and inotropes are really, really important in the acute decompensated heart failure state. The most common inotropes that we use here in our ICU are phosphodiesterase inhibitors or milrinone. That works to decrease the systemic vascular resistance or provide afterload reduction, and it increases inotropy or increases myocardial contractility. So it decreases the work the heart has to do, and it helps it work more effectively. And both of those are done without a significant increase in heart rate or oxygen consumption, which makes it really attractive. The problem is that it does decrease afterload and can actually cause hypotension in patients who are also already hypotensive, and so sometimes our doses can be limited, in which case we might need to use catecholamines such as epinephrine, which are beta agonists and increase both heart rate and contractility, but at the same time increase myocardial oxygen consumption and demand. And so we just need to be very careful about balancing that and not asking the heart to do too much. So oftentimes we'll end up on a little bit of milrinone and a little bit of epi, and hopefully find that balance to help improve the oxygen demand, or improve the oxygen delivery enough to help restore that balance that we were talking about. We also have a lot of non-pharmacologic therapies that we need to undertake in a patient in acute heart failure. So fluid and nutrition management is very important. As I mentioned, they're often volume overloaded, so we have to restrict volume, but at the same time increase the calories that they need because of the high metabolic demand that they're under. Sometimes we have to initiate tube feedings or even make them NPO in order to take away the work of eating, which again is a pretty significant demand in that state. Respiratory management is also very important. So taking away the work of breathing in someone who's in acute heart failure can really help to reduce that oxygen demand and restore the balance. Pain and anxiety management and sedation is also very important, especially in patients in the ICU, especially those who need to be intubated, for example. The agitation and agitation just really increases the metabolic demand. And so keeping them quiet, keeping them sedate can sometimes be a very important tool, and balancing that with the need to, the desire to not have them necessarily muscle relaxed, but at least calm is really important. And then fever is another really important demand on the body that can really tip a patient in acute decompensated heart failure over the edge. So making sure that we're keeping them normothermic is really important. Medical management in chronic heart failure is now more about maintaining the balance. So this is after we've sort of rescued them from their acute decompensated state. We start thinking further ahead about trying to get this heart better over time. So of course, we still want to manage symptom relief, but now we're going to be focusing a lot more on neurohormonal modulation and reverse cardiac remodeling, and again, trying to get that heart back to a more normal functioning state. So this is where this little diagram comes more into play. For the first, acute decompensated heart failure part of the management, we're really focusing up here, and then once we've gotten past that stage, we can start to focus on some of these other pathways. So first-line agents for chronic compensated heart failure are ACE inhibitors, ARBs, and more recently, Entresto has been introduced, which is an angiotensin receptor and neprilysin inhibitor, or ARNI, because we can never just, we have to come up with cute little acronyms for all of our medicines. This class of medicines provides afterload reduction. It doesn't increase myocardial contractility, but it provides afterload reduction and makes it easier for the heart to do its work. And it also, more importantly, perhaps, modulates the renin-angiotensin-aldosterone system and starts to sort of counteract that neurohormonal dysregulation that we see in heart failure. Beta blockers are also a critical component of chronic heart failure management. They block the sympathetic pathway, so also modulate neurohormonal dysregulation. They decrease heart rate, decrease oxygen demand, but they also can decrease myocardial contractility, so we definitely don't want to use them in the acute decompensated state. So those are medications we say for someone when they're a little bit, when they're definitely more compensated. Aldosterone antagonists such as spironolactone or eplerenone, these also modulate the renin-angiotensin-aldosterone system in addition to providing some diuretic effect. Diuretics such as Lasix or torsemide help to decrease filling pressures and decrease pulmonary edema. So again, these are important for symptomatic relief in patients who are still prone to congestion. And then digoxin is one of the oldest heart failure medications that's out there. It does have some potential toxicity, so I think sometimes, or for a period of time, people were steering away from it, but it actually really is a very helpful medication. It decreases the heart rate and increases myocardial contractility, which are both very helpful in chronic heart failure management. And although there have been lots of studies that have shown that digoxin improves symptoms and decreases hospitalizations for heart failure, there have never been studies that show that it decreases mortality, unlike the ACE inhibitors and beta blockers. That being said, improving symptoms and decreasing hospitalization is really important. So I think digoxin is still a very good tool in our toolkit to help treat these patients. Here's a little diagram of the mechanism of action of LCZ696, also known as Entresto. I'm glad we came up with a better name than that. As I mentioned earlier, this is a combination medication that includes both an angiotensin receptor blocker as well as a neprilysin inhibitor. And so you can see on the right here, the angiotensin receptor blocker blocks the renin-angiotensin-aldosterone system, and then the neprilysin inhibitor blocks the neprilysin system on the other side. So simultaneously, this medication is helping to counteract the negative effects of the RAS system and to augment the positive effects of the neprilysin system, because it helps break down, it helps inhibit the breakdown of neprilysin, so it leaves more in the system. So you're, again, having a dual pathway to help reduce vasoconstriction and reduce water retention and things like that. So that's the thought process and why this medication works better than ACE inhibitors or ARBs alone, because they have this additional component to them. There's other medications that we use in chronic heart failure. Hydralazine plus isosorbide dinitrate is a combination therapy that in the adult world comes as one single pill called Bidil. In pediatrics, we don't really have that option. We have to use the pills separately, which makes it a little bit challenging because it's also given 3 times a day. But it actually is a really good choice of medication, especially when ACE inhibitors or Entresto are not tolerated, because it doesn't have the effects on potassium and renal function that that class of medications can sometimes cause problems with. Ivabradine is another medication that helps to lower the heart rate, but without affecting blood pressure or contractility. So it's a nice adjunctive medication when beta blockers are not tolerated due to symptoms or low blood pressure. And oftentimes we'll end up with lower doses of the first-line medication, and then once we get to a point where we can't increase any further, we can add these medications as adjuncts. Dapagliflozin is a newer medication that's been introduced to our heart failure armamentarium. It's an SGLT2 inhibitor, was originally designed to treat type 2 diabetes by inhibiting, or I guess increasing glucose excretion out of the kidney and decreasing blood sugar levels. But during the studies that they were sort of following the effectiveness of these medicines to treat diabetes, they found that it really helped patients who had heart failure. And a lot of patients with diabetes have heart failure. So they were like, oh, we should look into this further. And in fact, they found that it helps in patients with heart failure with reduced ejection fraction, in heart failure with preserved ejection fraction, in heart failure with chronic kidney disease. So it really, in study after study, these medications have been shown to be really helpful. I don't think we really fully understand the mechanism of action and why these medications help in patients with heart failure, and there's lots of research going into that right now. But these medicines, like I said, have found to be really helpful, and they have very relatively few side effects. They don't affect blood pressure or heart rate like some of the other medicines that we use do. They do have some side effects that they increase risk of urinary tract infections and some other things, but generally are very well tolerated. And even our group here has published our early clinical experience with DAPA in children with heart failure, and so I think this is going to be more widely used in pediatric patients across the country. So we'll see how the data continues to evolve, but hopefully this will be another great addition to our toolkit. So now I'll talk a little bit about extracardiac medications in heart failure. Yes, we do have to think about other organ systems as we take care of patients with heart failure, of course. Anticoagulation is always a hot topic of conversation in our patients with heart failure. We know that patients with dilated cardiomyopathy in particular have an increased risk of intracardiac thrombosis, as well as systemic thrombosis related to just low flow state, and we think of cardiomyopathy, or I guess we think of heart failure as being a pro-inflammatory state as well, which really increases the risk of thrombus formation. There are some guidelines in the adult world about when to start anticoagulation in patients with heart failure, and they tend to reserve that for patients with the lowest ejection fractions, but there are patients who might have additional risk factors. So either aspirin or something stronger. And when we have patients in the hospital, especially with indwelling lines, we have a very low threshold for starting them on anticoagulation due to their high risk. Iron deficiency and anemia in heart failure is also really important. We know that it's very common in patients with heart failure, and we also know that iron deficiency and anemia can lead to decreased oxygen delivery, which then increases symptoms and risk for decompensation. So management of heart failure should include regular monitoring and correcting for anemia and iron deficiency. So in our inpatients especially, but even our outpatients, we check iron studies regularly and consider IV iron replacement if oral iron replacement is not enough. We also may consider darbepoetin to help improve red cell production and prevent the need for transfusions. And then there's also non-pharmacologic therapies in heart failure that focus more on arrhythmia management, and et cetera. So first and foremost, if you have a surgical problem, such as a ventricular septal defect or a primary valve problem, we need to fix that problem in order to address the heart failure. So that's especially in patients with congenital heart disease. Fixing any anatomic problem is really the first line therapy for treating that heart failure. And if you can't fix it, then we try to palliate it. So the primary tenets of palliation in congenital heart disease are to limit pulmonary blood flow, to provide, enough but not too much pulmonary blood flow, and to ensure an unobstructed systemic outflow. So, depending on the anatomic lesion, we really try and find a way to address that either surgically or in the cath lab. Now, if you have advanced heart failure, whether that be from congenital heart disease or cardiomyopathy, that we can't rescue you with medical management, mechanical support may need to be considered. And our primary modes of mechanical support are ECMO and BAD, which we'll talk a little bit about in a second. And then in the end stages of heart failure, when we have tried all of those things and we don't have, and we're not moving in a positive trajectory, then we do need to consider heart transplant in some cases. So mechanical support options, as I mentioned, ECMO, that is fast and relatively easy to perform, but not the greatest long-term option given the risk of bleeding and the needing to be, in the hospital bed and in ICU for long periods of time. We have a couple of options for longer-term, more durable mechanical support that allow patients to leave the ICU and sometimes even leave the hospital. Our two most common versions are the HeartMate 3, which is down here. Sorry, my cursor, there it is. This is a picture of the HeartMate 3, which was recently FDA approved in children, but really can only be used in bigger children. But it's a really wonderful implantable left ventricular assist device that can be, that patients can actually go home with. So that makes it a really nice option for long-term durable support. Our second most common is the Berlin heart, which can be used in smaller children. It does a really nice job of supporting our smaller patients. The downside is that it can't be discharged from the hospital because of its external pump situation. And so I think many of you know, we recently had a patient in the hospital for 17 months with the Berlin heart. So again, provided great support to her and made her a very, very healthy heart transplant candidate. When she got her heart, she was wheeling around in just a couple of days and is now home. So they're really great options, all with their downsides, of course. Other options include the Impella, which is over here on the right. It's plastic-based implantable device and is really more for acute temporary support, but it can be very helpful in those situations. The total artificial heart over here, we don't do that very often here at Seattle Children's, but for patients with biventricular failure or reasons that they can't use some of these other devices, the total artificial heart is an option. And these devices can all be either a bridge to recovery or a bridge to transplant, depending on the situation. I think it's important to remember that there's, besides the function, the electrical activity of the heart is very important. We work very closely with our electrophysiology colleagues to talk about a lot of different issues in our heart failure patients. ICD is one of them. Our patients with heart failure are definitely at increased risk of having life-threatening arrhythmias. And so ICD or implantable cardiac defibrillators can be used to protect them from that. And they come in various different versions. So you can have an abdominally placed generator with leads on the heart here. You can have a transvenous. With epicardial leads, you can have a transvenous system where the leads go through the vein into the right heart, or you can have these newer subcutaneous versions where the generator is out here and the lead is inserted subcutaneously just under the skin. So less invasive, but still effective at preventing sudden cardiac death. And then for patients who aren't ready to proceed or for some reason can't get an ICD, they do have these life vests that patients can wear chronically to help protect them from life-threatening arrhythmias. And when we think about ICD placement in children, we do have to remember that they have a lot of growing to do. They might have unusual anatomy, but we do have to consider these devices in certain patients. Pacemaker and cardiac resynchronization therapy might also be an important consideration. Cardiac resynchronization therapy is well established in adults. I think we have less experience with it in children, but I can tell you from experience here at Seattle Children's in my career, we've seen very great success in certain cases using cardiac resynchronization therapy. So really in the setting of cardiomyopathy, when the conduction system is abnormal and leading to inefficient mechanical stimulation or electrical stimulation of the heart, we can restore that synchronization using the appropriately placed leads and restore that synchrony and really improve the function of the ventricle. And I've seen really, like I said, really great success where the function has normalized after resynchronization therapy, avoiding the need for heart transplant. So when I think about all of this, I think about what it would be like, what it's like to take care of a child with heart failure at home, and realize we prescribe a lot of these medications. Many of them have side effects, low blood pressure. We try to prevent arrhythmia, but we can cause arrhythmia with some of our medications. They might cause electrolyte disturbances, renal dysfunction, GI upset. They require a lot of lab draws for monitoring. Just the act of taking the medicines can be a challenge. And on top of that, we ask them to come to clinic and, like I said, go to lab and things like that. And I think it can leave our families feeling really wiped out at times. And so that's why I'm always thankful to have such a great team of not just doctors and nurses, but also social worker and psychologists to help us take care of these patients and their families as they're going through these really challenging times. So, you know, I talked about how we can hopefully help patients with heart failure by using medical therapy and some forms of non-medical therapy to really get them feeling better. But there are times where no matter what we do, we can't save them and their heart continues to fail. So then we have to start talking about heart transplant. And I'm going to list here some very sort of technical terms that that we have listed based on sort of the UNOS language for indications for heart transplant. But basically, when a patient has uncorrectable or end-stage heart failure that risks their that puts them at risk for imminent death, that puts them at risk for being unable to participate in their activities of daily living or development, that puts them at risk for malignant arrhythmias, and or they have advanced heart failure that without intervention would be expected to cause damage to other organs, such as in a failing Fontan, we get concerned about liver failure over time. This is when we start to think about heart transplant. And in very basic terms, I think about when a patient is unable to do the things that they want to do in their life because of their heart failure. So if they can't go to school, for example, if they can't eat, if they can't gain weight, those are the things, sort of the things that make me start to think about whether heart transplant is indicated for this patient. Now, there are contraindications to transplant. Some of them are absolute, some of them are more relative, but as we kind of add up the contraindications, we do have to understand that the risk profile increases. So non-cardiac diagnosis that can substantially diminish the success or benefit of a heart transplant. So that's someone who might have another diagnosis that's going to limit their life regardless of whether or not their heart gets transplanted. End organ dysfunction enough to significantly increase the morbidity or mortality of the heart transplant. So someone who has renal failure, for example, and can't get a renal transplant, we wouldn't want to do a heart transplant because they would still have issues that we couldn't fix with just the heart transplant alone. Malignancy, an active infection that would alter our ability to provide immunosuppression, bleeding risk, irreversible pulmonary hypertension. HLA sensitization is more of a relative contraindication that does increase the risk of rejection after transplant, but we often have ways that we can manage that. Drug and alcohol dependence is listed as a contraindication to heart transplant, also probably a relative contraindication if we can get them into a treatment program. And then insufficient support by family, guardians, and caregivers is also a relative contraindication to transplant and something that we unfortunately have to deal with sometimes. But again, we do have a really awesome group of social worker and psychology partners on our team who help us work through some of these issues. When I think about transplant, that I have to always remember there's special challenges in patients who have congenital heart disease. I think the surgeons will tell you that heart transplant can be either the easiest operation that they perform if it's just a straightforward cardiomyopathy where all of the vessels are where they're supposed to be, or it can be the most challenging operation they perform where nothing is where it's supposed to be and they're trying to fit this sort of normal heart into a very abnormal situation. But patients with congenital heart disease can have great artery anomalies or venous anomalies, and sometimes even dextrocardia, where the heart is on the wrong side of the chest, that the surgeons have to somehow figure out how to get that new heart in there and working properly. They often, because they have congenital heart disease, they've had surgery before, which makes going in again challenging. They can have a lot of scarring, adhesions, lots of AP collateral vessels that make bleeding an issue. And so those operations can, again, be really challenging just from a technical standpoint. Patients with congenital heart disease, because they've had previous operations, are at higher risk of having HLA sensitization, which again increases their risk for rejection. And so that's something that we as the transplant cardiologists need to be aware of beforehand. We may need to desensitize them, and we may need to alter their immunosuppression after transplant in order to help prevent rejection. And these patients often have extracardiac disease just because of their sort of chronic issues. So we always have to keep those things in mind. And timing is everything when we're talking about transplant. It's typically a joint decision made between the primary cardiologist, the transplant team, the cardiac ICU, CT surgery, depending on where the patient is. And really the patient and family are probably the most important consideration in that decision making. The things we consider, again, symptoms, Sometimes it's very obvious the patient can't get out of the ICU, the patient needs a heart transplant, but sometimes the patients are at home and really, trying to decide what is acceptable quality of life to them can be a challenge. We have to consider the likelihood of success or availability of other interventions before we consider transplant. We have to think about the likelihood of the patient surviving the transplant. So how sick is the patient now? Are they expected to get a full recovery after transplant? We think about how old they are, again, their HLA sensitization, where they are in the hospital or not. And so these are kind of all of the things that we think about as a team when we're thinking about when to proceed with transplant. So I'm going to close the talk with just a case study. This is a 3-month-old who presented in acute decompensated heart failure. So all the signs and symptoms we were talking about: increased work of breathing, poor feeding, poor weight gain, just not looking good. They got an echocardiogram that showed a very dilated left ventricle, an ejection fraction around 20%, which is really bad, severe mitral regurgitation. Their EKG showed ST and ST changes and Q waves consistent with ischemia. And the patient had a cath, which confirmed a diagnosis of anomalous left coronary from the pulmonary artery, which is one of those rare congenital coronary anomalies that can lead to an ischemic cardiomyopathy. So this patient had really bad heart failure, a really ugly looking echo, but we knew what to do. The child underwent surgical repair, so they replaced the coronary where it's supposed to be, and we now have good oxygenated blood going to that heart muscle. However, the LV remained severely dilated and dysfunctional for a long period of time. What should we do? Should we send the child to transplant? I'll show you the pictures and see if this helps you decide. If I can maybe, here we go. Let's see if we'll get them to play. So this is the initial echocardiogram. And you may not have looked at a lot of echocardiograms in yourself, but this is a hugely dilated left ventricle and it doesn't work very well. So 1 year later, oh, it looks the same. 1 year later, we've had the patient on cardiac remodeling medication for a year now, and it still looks like this. So I'm starting to get a little worried. But when I look at the patient, she's running around the room, she's growing, she's developing. And so we decided to hold off and just keep doing what we're doing. And I'll tell you, if you fast forward 3 years later, sorry, here we go. This is the same patient. This heart has remodeled to now normal function, normal size, and the patient looks fantastic. So the wonders of carvedilol, right? And time. We were very happy. I was happy and sad to have to graduate this patient out of heart failure clinic because she was doing so well. So we're very happy to see that. Like I said, we're, as a heart failure and transplant cardiologist, I'm happy to graduate patients out of my clinic and not have to give them a transplant. So in summary, I hope I've convinced you that heart failure is a clinical syndrome with a final common pathway of neurohormonal dysregulation and associated symptomatology. And understanding the cause and physiology of your patient's heart failure is paramount to individual patient management. Medical management options aim to restore the balance between oxygen demand and delivery, reduce symptoms, and ultimately to halt or reverse the vicious cycle of heart failure. And surgical interventions and options aim to fix the problem or reduce symptoms and palliate until recovery, hopefully, or transplant as a last resort, but hopefully recovery. And I think that's all I have for you. And I'm happy to answer any questions that anyone has. Thanks for listening.
Thank you so much. Folks, if you have questions for Dr. Albers, please put them in the chat. I can read them on your behalf. We do have a number of community nurses in our presence. So I'm curious if you have, since you do outpatient care as well, what is a common thing that a heart failure patient would be to get readmitted into children's?
Oh, well, I think, you know, when we have patients who are out in the outpatient world and we know, you know, they're on medications, we know at any time they could really tip into that more decompensated state. And things that tend to tip them over are intercurrent illnesses. So a viral illness that normally you or I would just, you know, maybe stay home for a day or two, that can really tip these kids over. Things like fever, just anything that increases the demand over their baseline. They just don't have any margin. So we watch those kids very carefully, but they do present with symptoms of heart failure that we talked about. So increased work of breathing, poor feeding. Feeding intolerance is really probably the first and most common sign that we worry about in those patients, and work of breathing. So we will often have to say, we will often ask those patients to be seen frequently by their pediatrician and to be looking out for things like that to help us know if they need to come back into the hospital.
Mm-hmm. And then for those patients who you deem are now, like, they should be getting a heart transplant, would they manage that? Would they stay out of the hospital while waiting for transplant, or would they be admitted while waiting for transplant? What would that process look like?
Oh, that's a great question. And it really depends on the patient. It can be either one, actually. We have a number of patients who are listed in the hospital right now, but we also have a couple who are waiting at home. Patients who wait at home are listed at a lower urgency priority on the list. And so, you know, they will have to wait longer for a heart, which is probably appropriate if they're waiting at home. But we take all of that into consideration, their symptoms, their likelihood of getting a transplant, and those sorts of things. And also the psychological impact of being in the hospital versus not. You know, if they're well enough to be at home, we do everything we can to keep them at home, just because it really can be challenging to stay in the hospital and wait.
Mm-hmm. Just a few comments in the chat. Thank you for a great presentation and a comprehensive overview. If there aren't any more questions, we can thank Dr. Albers, and we'll see you next time for our next nursing grand rounds. Thank you so much.
Awesome. Thank you, guys. Have a good day.
Have a great rest of your week. Bye.